Hi everyone, I'm Dr. Quek. I'm the Associate Consultant from the National Neuroscience Institute SGH campus, and my colleague Zichun, who is a Senior Medical Technologist from the National Neuroscience Institute. We are going to give a talk about the stroke workup, in particular about neurosonology. So the outline for this lecture today will be an overview of stroke as well as the stroke etiology, what are the causes that can lead to the stroke, and what are the clinical indications for carotid endarterectomy, as well as carotid stenting in those patients with carotid artery stenosis. I'm going to touch a little bit about the hemodynamic in severe carotid artery stenosis, and my colleague Zichun is going to talk about the technical perspective of carotid ultrasounds as well as a transcranial Doppler. We know, right, overall, for the ischemic stroke in Singapore, estimated there will be about 8,000 cases a year, where there's one patient who will be suffered from stroke in every 6 population. This is based on the national data that was collected in the year of 2016. The next classification for the stroke is what we call as TOES classification. In general, under TOES classification, there are 5 different causes that can lead to the stroke. The first one will be large artery disease, cardioembolic stroke, lacunar stroke, other causes that can lead to the stroke, as well as the causes that which are unable to find after we have fully investigated the patients. My targets in this talk today, I'm going to talk about many large artery disease which involve what I call the extracranial carotid arteries. In terms of acute stroke care, the most important part is the acute infarct itself, the things that we can do in order to salvage the penumbra area in order to help with the patient's functional disability. Subsequently, the stroke as well as the complication preventions will be what we do in order to help to reduce the stroke recurrence rate. The secondary stroke prevention is very important as we can help to reduce the risk of recurrent stroke, and these are the things that we have to do, especially with ultrasound carotids, to identify whether there is presence of extracranial carotid artery stenosis. I will talk about a little bit on cerebral circulation. As we know, we have 2 different divisions in terms of our blood supplies towards the brain. The first one is what I call extracranial, and the second one will be intracranial, or our circle of Willis. Extracranial arteries involve our extracranial carotid arteries as well as vertebral arteries and our arch of aorta. In terms of intracranial vessels, or our circle of Willis, they are generally your anterior cerebral artery, middle cerebral artery, posterior cerebral artery, as well as the intracranial internal carotid artery, vertebral, as well as basilar arteries. My targets today is I'm going to talk about extracranial carotid arteries and the involvement of ultrasound carotids in regards to the investigation of those patients presented with acute ischemic stroke. So the next slide basically shows the diagrammatic picture of internal carotid artery extracranial as well as intracranial internal carotid arteries, which eventually end up with a middle cerebral artery and anterior cerebral arteries. So I'm going to touch a little bit about the management of symptomatic carotid artery stenosis, especially in those patients with severe symptomatic internal carotid artery stenosis. As we know, the management in those patients with symptomatic severe internal carotid arteries, the gold standard treatment will be carotid endarterectomy, because according to this NASCET trial, the efficacy of carotid endarterectomy is significantly much better as compared to medical treatment alone. From this slide, we can see that the measurement in terms of the internal carotid artery extracranial, we can use either the NASCET trial or based on ECSD trial. If we were to base on the NASCET trial, we can see from this picture is that they are using A minus B, where this A is the normal diameters of the internal carotid artery distal to the areas of significant narrowing. And NASCET formula will be A minus the B. B will be the stenotic areas with the denominator of A. And according to ECSD trial, they are actually using C minus B, where C is supposedly should be the normal diameter of the internal carotid arteries at the stenotic area with the denominator of C. And from this diagram itself, we can see the differences between the postulated, the diameters of the stenosis according to NASCET as well as according to ECST trial. We will notice that for ECST trial, they actually suggested for CA in those patients with carotid stenosis of at least 80 to 99%. That's why, because in a patient who has got this ultrasound carotids done, it will be better for us to determine whether the calculation is based on ECST or NASCET trial, because ECST as well as NASCET trial, there will be at least about 20% different. This is generally the next slide showing that the risk of stroke as well as the severity of carotid stenosis in those patients with symptomatic internal carotid artery stenosis. According to this NASCET trial, in those patients with at least 70 to 99% of internal carotid artery stenosis, in those patients who undergo surgical treatment, for example, carotid endarterectomy as well as stenting, showing that they are actually doing better, where there's a significant reduction of ischemic stroke recurrence as compared to those patients with medical group alone. And the number needed to treat is only 8. So from this study, we can tell us that it is very important that ultrasound carotids has to be done to identify what can be the cause and to identify whether there is presence of extracranial carotid artery significant stenosis leading to the stroke. In some of the patients who are not eligible for carotid endarterectomy, then we will subject them for carotid artery stenting if there's presence of extracranial, symptomatic severe internal carotid artery stenosis. So these are the criteria where those patients will benefit more if they were to go for carotid artery stenting. So the first one will be carotid lesion that's not suitable for surgical access. For example, in those patients with irradiated neck, with underlying nasopharyngeal carcinoma who went for the radiation therapy before, where there's a distortion in terms of the anatomical structures of the vessel itself, or in those patients who after underwent carotid endarterectomy and there's presence of restenosis, as well as those patients who are unable to go for general anesthesia, especially in those with significant cardiac pulmonary comorbidities. So now I go through a little bit in terms of the technical part of this interpretation of Doppler blood flow. And as we know, our blood flow generally is going through via laminar flow. So this is how the laminar flow looks like when the blood flow going through a normal internal carotid arteries. So what exactly it will look like if there is a significant stenosis of the carotid arteries. So when there is a significant stenosis or there's a presence of significant plaque over the internal carotid arteries, then it will become turbulence flow, where there will be a change in terms of directions. The flow will become very chaotic. The flow will be disturbed. My next slide showing the indices in ultrasound carotid studies. There are a few parameters which are important to us, especially during the performing of these ultrasound carotids. So the first one will be our peak systolic velocity, and the second one will be end diastolic velocities. From this picture, we can see how it looks like the normal waveform in the normal patient with a normal carotid arteries. With the peak systolic velocity, as well as the end diastolic velocity, we will be able to calculate our mean velocity as well as a pulsatile index across the vessels itself. As we know, there's the presence of what we call Spencer curve to determine the relationship between the flow, the velocity, as well as the lumen size. So from this graph, we can see that when there is a significant reduction in terms of the diameter of the vessels, especially over the 70%, there's a significant reduction in terms of the blood flow, as well as there's significant change in terms of the velocity across the stenotic area. So that's the reasons carotid endarterectomy as well as a carotid artery stenting is indicated in those patients, especially they present with symptomatic severe at 70 to 99% stenosis of the carotid arteries. Now, I'm going to talk about what are the consequences of steno-occlusive disease based on the ultrasound carotid studies. There are two ways. One is direct visualization, and the second way is indirect evidence based on what we find from our ultrasound carotid artery. So in regards to the direct visualization, we generally can divide into 3 segments. The first segment will be at the stenotic area, where what we can see in terms of the stenosis. Then the second segment will be immediately after the stenotic area, as well as the third segment will be proximal towards the stenotic area. So for the first one, the downstream effect, or immediately after the stenotic area, we will expect to see a very dampened flow or blunted flow. However, at the stenotic area, we are going to expect to see there's a significant increase in terms of the peak systolic velocity. In regards to the upstream effect, or proximal towards the stenotic area, we will expect to see there's a presence of pulsatile flow as well as lowish velocity flow and dampened flow. In regards to the indirect evidence, in the proximal arteries, sometimes we may notice there's a presence of significant asymmetry in terms of flow velocity over the right and the left carotid arteries. Occasionally, we may notice there's presence of small arteries in the absence of significant disease, which may suggest the disease actually has been chronic. Collateral flows can give us other ideas to suggest whether there is presence of proximal or distal internal carotid artery stenosis. My next slide actually showed the diagrammatic pictures, illustration on if there's presence of a significant stenosis over the right internal carotid arteries. So I'm again going to divide it into three segments. The first segment is the upstream effect at the stenotic area, as well as immediately after or downstream effect. So the diagrammatic pictures, the ultrasound pictures here, showing what exactly is the waveform that you're going to expect to see at the stenotic area, distal to the stenotic area, as well as proximal to the stenotic area. So I'll go through the first one, where you're going to see there's a significant dampened flow, blunted flow, with you are going to expect there's presence of delayed systolic acceleration at the areas where you insonate distal to the stenotic area. If you were to insonate over the areas of significant stenosis of the internal carotid arteries, you are going to document there's a significant increase in terms of the peak systolic velocity across the stenosis. How about your upstream effect? You're going to expect to see there is a significant pulsatility of the flow proximal towards the stenotic area. So basically from this ultrasound pictures, we kind of like able to tell there's a presence of significant hemodynamic change across the significant carotid artery severe stenosis.
Now I'll be talking about carotid Doppler ultrasound on the technical point of view. Ultrasound of the carotid arteries is a procedure that is painless and has no side effects. It is used to screen for any blockages of blood vessels that supply blood from the heart to the brain. It also provides information on the types or texture of plaques and real-time images of mobile clots or thrombus. Other purposes of ultrasound includes evaluation of vessels post-carotid endarterectomy, post-stenting, and also for detection of carotid abnormalities such as aneurysm. So how does carotid arteries look like on ultrasound? There are a few modes we use during ultrasound screening. First is the beam mode function, which provides us with a 2D overview of the blood vessels. This image shows a typical normal carotid artery in sagittal view. Beam mode function also provides us with information on the type of plaques that are visualized, such as whether they are hypoechoic and mobile as in the first image, or non-mobile and calcified in the second image. We are also able to visualize structure abnormalities such as aneurysm and patency of stent post-surgery. Another modality used during ultrasound is the power angio mode. This mode lets the operator know whether there is flow in the vessels, especially when the flow is minimal. However, it does not provide any directional flow. Color Doppler mode, on the other hand, provides us with information on the direction of flow. Red is set as arterial, while blue is set as venous flow. Turbulence flow could be frequently seen at bifurcation and also when there is stenosis. Pulse wave mode or Doppler mode shows us the speed of blood flow at the point of sampling. Flow velocity ratio of ICA peak systolic to CCA peak systolic is used to grade stenosis. Ratio of more than or equal to 2 is considered a 40 to 60% stenosis. ratio of more than or equals to 3 is a 60 to 80% stenosis, while anything that is more than 4 is usually a 80 to 99% stenosis. However, there are times whereby flow velocity ratio could not be used for bleeding, as flow velocities in ICA could be very low or minimal, which is suggestive of a distal obstruction or a near occlusion in the ICA. Transcranial Doppler, or TCD in short, is another ultrasound modality used to examine the blood circulation within the brain. Like any other ultrasound, it is painless and has no side effect. Another plus point is that it is portable and could be done bedside. Therefore, it is commonly used for detection of vasospasm following a subarachnoid hemorrhage or stenosis of intracranial vessels in stroke patients. TCD is a blind technique which requires a lot of patience and experience to perform. Blood vessels are identified based on window used, the depth at which ultrasound is insonating, the direction of flow of vessels, and also the characteristics of Doppler waveform. However, one major drawback of TCD is that patient could have a suboptimal temporal window where the skull is too thick for the ultrasound waves to pass through. Therefore, no Doppler waveform could be captured. This slide shows the different windows which could be used to assess the different vessels within the brain. Transtemporal artery window, which is located at the temple of the patient head, could assess the MCAs, ACAs, and PCAs. The direction of flow of MCAs and PCAs are towards the probe, while ACAs are away from the probe. Transorbital window could assess carotid siphon and ophthalmic arteries. Patients are asked to have their eyes closed gently while the probe is placed on their eyelids. Patients with contact lenses are asked to have them removed. Lastly, transforaminal window, which assess the vertebral arteries and basilar arteries, are located at the base of the neck. So the take-home message for this presentation is carotid ultrasound is an important investigation in stroke evaluation. Symptomatic carotid artery stenosis is a well-known cause of ischemic stroke, where early intervention helps to prevent stroke recurrence. Lastly, carotid ultrasound and TCD are inexpensive and non-invasive modalities for assessing arterial sclerosis of extracranial and intracranial vessels respectively. Thank you.